Thank you so much. So special thank you to you and to Marty and the SAPA webinar organizers for this opportunity to spend an entire webinar focusing on poisoning in childhood. It's a great privilege and we thank you for that. So we'll start by highlighting the prevalence and impact of childhood poisoning, both globally and locally, and then go through a generic approach to the poisoned child and the resources available to you in managing such a child. And lastly, we'll illustrate some common or important types of poisoning with some case studies. So how big is this problem of poisoning? Now, if we look globally at all deaths, approximately 1/4 are linked to the environment. And of these, we see that the fourth highest, this orange circle here, is unintentional injuries. And half of these are due to acute poisonings. However, these are not the only circumstances under which poisoning occurs. And we know that up to 20% of the 800,000 annual suicide deaths globally are pesticide related. And we see this trend in South Africa as well, with even children of 10 or 11 years engaging in this kind of self-harming behavior using pesticides. So looking at this a slightly different way, this is a tree map from the Global Burden of Disease Project. It shows mortality data for all ages, and it illustrates very clearly the predominance of non-communicable causes of death. Those are shown in blue. And you can see that poisoning, which is part of the injury-related deaths, shown in green, accounts for a mere 0.14% of all deaths. And this is all age data. But what about children? So looking at the same data for children under 5, although the proportion due to poisoning you will see is higher, it's 1.5 times that for all ages, still at 0.21% of all deaths, this is clearly overshadowed by the much greater burden of communicable diseases and nutritional disorders that are shown in pink. But of course, this is an average, and the reality is that outcomes for children are hugely dependent on where they live. And so this last slide using global burden of disease data shows the under 5 mortality from poisoning per 100,000 population across the world. And you can see that if you live in the Eastern Cape, you are 130 times more likely to die from your poisoning incident as a child than if you lived in Ireland. And we know, even in our own country, that mortality rates vary considerably between the provinces. So now, as useful as this global burden of disease data are, much of it is modeled. And so let's look rather at the actual data we collect in South Africa from our 24-hour poison information helpline service. So since the mid-2015 or so, the poison centers at Red Cross War Memorial Children's Hospital and Tygerberg Hospital combined their expertise to launch an essentially national poisons helpline running 24 hours a day, 7 days a week, that can be reached by members of the public and health workers for assistance with managing poisonings. Now, we can say today that it's a 24-hour service for now, but last week, that 24-hour service was under severe threat as we rely on donor funding to provide a full 24-hour service. And our funds had run out, but we are most grateful to the benefactor who came forward and offered funds to keep us going. So we, at this point, going for at least another 3 months. And we would like it, obviously, to be permanently available. So looking at the last 3 years of data, you can see 2021 in blue, 22 in orange, and this year in red. We receive well over 1,000 calls per month. And as you can see, we are busier in the summer months than in the winter months. And the monthly average over the last 3 months has been well over 1,100 calls each month. We receive calls from all provinces, but predominantly Gauteng, KwaZulu-Natal, and the Western Cape. And 2/3 of our calls come from health workers, and most of those are doctors. So this chart ranks the types of toxins we see, and this is particularly for children under 12 and looking at the data from last year. So almost half of the cases are pharmaceutical exposures, 44%, and this includes both over-the-counter and prescription medications. Next, the household chemicals or handyman chemicals such as bleach or kitchen cleaners, laundry detergents, thinners, and of course paraffin. And these accounted for about 1/4, 24%, And third commonest from our poison helpline data were the pesticides at 12%. And as we'll see later in the presentation, and shown recently in the paper published by Mahtab Khan, looking at the Barra pediatric data, pesticides tend to result in more severe poisoning. So looking at the data more closely, we see that children 12 years and younger made up 46% of all the calls we received, and 80% of these, of course, under 5 years. And the table on the right lists the substances that cause the most severe symptoms and signs in the under 5s, and medications are top, most frequent, and particularly psychiatric meds, then the anticonvulsants, cold and flu remedies, and analgesics. Secondly, pesticides, and I think we're all very familiar with organophosphates, but also the formamidine insecticides, which are commonly found in cattle dips. Thirdly, antiseptics, and specifically potassium permanganate, used widely, which can cause quite serious chemical burns. And then lastly, paraffin, which is still prevalent in many communities and can cause a very nasty chemical pneumonitis. So this brings us to the end of this part, a description of the context of childhood poisoning, both globally and in South Africa. And Kate is going to continue for now looking at an approach to the poisoned child and the resources available to assist with management. Thanks, Kate.
So thanks, Cindy, and good afternoon to all of you online. As Cindy said, I'm going to go through how you might encounter these poisoned patients in your clinical practice. So firstly, it's always important to remember that childhood poisonings are quite different to adults, in that most cases are accidental, small exploratory ingestions, whereas adults are either exposed in the workplace to highly toxic chemicals or take large intentional overdoses of multiple substances. The stages of development in children actually also highlight this adult-child delineation, as a toddler may ingest a small amount of a household product, whereas an adolescent can take an intentional overdose of multiple medications. So when dealing with a poisoning, as per always, it's good to take a good history. If the ingestion is known, then inquire as to how much was taken. It's so important to differentiate between a simple exposure to a harmful substance and an actual poisoning. And this is termed the toxic dose, which is the dose at which most people will experience toxicity. All further management is based on this. It's used to triage patients, whether they are calling from home or they've presented to the primary healthcare facility. Sorry, there's some noise coming through. Or even if they are admitted in the ICU, as it helps to anticipate the potential severity of a poisoning and decide on the most appropriate level of care for a patient. Toxic doses are, of course, easier to determine for medication overdoses, as they're based on case reports for common poisonings. For some medications, even just one tablet may be harmful, but for others, the whole packet is not a problem. The toxic dose is, of course, a little harder to define for household products, and toxicity due to corrosives, such as acids or potassium permanganate, as Cindy mentioned, or bleach or drain cleaners, or otherwise the hydrocarbons, which include paraffin or turpentine, and then some topical or inhalational exposures. These toxicities are not dose-related, but rather concentration-related, or they may have an aspiration hazard or even an irritant effect. And some common products are not harmful at all, but rather a choking hazard. Some pesticides, such as the anticoagulant superwarfarins, are really not harmful in an accidental ingestion, but others are potentially lethal, and Cindy will show you examples of this a little bit later. So if a toxic dose has not been ingested, please take no further action. And this means do not do gastric lavage, do not give activated charcoal, and certainly do not unnecessarily admit the patient for overnight observation. So the take-home message here really is that many minor incidents can safely be observed at home. But where a toxic dose poisoning has occurred, of course, further management is then required. The route of exposure is also important. Of course, oral ingestion is the most common route, and absorbed toxins cause systemic toxicity. Although an ingested corrosive product is more likely to cause local effects, if enough is absorbed, it may also cause systemic effects. And some inhaled products, such as carbon monoxide, will cause systemic effects, but others may cause more local respiratory effects, such as we all know the paraffin chemical pneumonitis. Skin or eye exposure to a corrosive may cause chemical burns, but some substances, such as organophosphates, can actually be absorbed through the skin to cause systemic effects. So the route of exposure really determines the timing of onset of symptoms, as well as one's options for decontamination. Okay, so we all know that we have to examine our patients carefully. But with poison patients in particular, we must pay attention more to the central nervous system, as well as the cardiovascular system. And please include things like pupil examinations, observe for things like muscle fasciculations, and even strange smells. The toxidromes that I've listed here may or may not be present, and they're a bit more helpful in the context of when the history of ingestion is unclear. So I've just shown you some of the more common toxidromes, and notice how the opiates and sedatives have a lot of overlap. But in most patients, not all the features of a toxidrome are always present. When it comes to managing our patient, supportive care is the mainstay of management. And if we get this right, our outcomes will mostly be good. You must spend time optimizing kidney and liver function, give respiratory and cardiovascular support. For toxic seizures, we suggest using benzos as first-line therapy. And if you need further medical management, then you can consider phenobarb or sodium valproate. But we like to stay away from phenytoin, as many drugs are cardiotoxic in overdose. So please remember this in your practice out there. For isoniazid toxicity, pyridoxine is actually the treatment of choice for seizures. But unfortunately, this has to be given orally, as we don't have access to IV formulations. And it means a large pill load that needs to be crushed up and often given via NG tube. When it comes to investigations, the type of poison and clinical presentation guides this. So the usual bloods are renal function and electrolytes, maybe a liver function if relevant, or blood gas or ECG. And some bedside tests are helpful. So the multi-drug urine dipsticks that you might have seen in your casualties test for the presence or absence of drugs, but it's drugs of abuse. So these are things like benzos, opioids, cocaines, amphetamines. But sometimes common household medications can actually result in misleading positives in this context. For example, many of the cold and flu medications contain pseudoephedrine, which will then come up positive for amphetamines. Codeine containing syrups can give us a positive morphine also. But a negative dipsticks also doesn't mean that a substance has not been ingested. It may be that it's too early to pass through the kidneys and then is not yet in the urine, or it might be that the drug's metabolized in the liver and then excreted in the stool. The one big group of investigation that always confuses everyone is tox screens, this entity of tox screens. So exactly what it is what is tested for actually depends on the lab that's available to you. So sometimes the lab, when you send off a tox screen, will just do the urine dipsticks that I've just explained to you before. Sometimes they might be able to add on a serum paracetamol level or salicylates or tricyclics. Some places we've seen carbamazepine or phenytoin. And in these cases, they're giving quantitative serum levels, which are really more helpful in a poisoning due to a known substance. In more advanced setups, something called urine mass spectrometry is available. And this looks for the presence or absence of any substance in the urine according to its molecular weight. So there's a whole library of options for this one, including pesticides and all sorts of things. But it's been shown that its utility in acute care can be quite limited. So as I said before, tox screens really depend on what is available at your lab, and you need to find out what they can offer you. But we also suggest that if you're unsure, rather ask us what testing might be relevant before embarking on expensive and unnecessary investigations. Prevent absorption of the poison. So skin and eyes in particular need to be washed thoroughly. You must use fresh running water or saline and don't reuse the irrigation solution. So we often tell parents at home to put their child in the shower rather than a bath. And then with regards to eyes, a lot of people might need analgesic drops to really irrigate them effectively. Gut decontamination measures include activated charcoal, gastric lavage, and whole bowel irrigation, but there really is no evidence to support the use of induced vomiting. Charcoal is reserved for substances which are absorbed by it and where the patient, most importantly, has a protected airway. So in other words, the patient must be either fully awake and cooperative or intubated. So many of our patients don't fit into these two groups. If they are all obtunded or combative, they really are. It is more dangerous to give charcoal than what the benefit you're trying to give. And charcoal also has to be given within 1 to 2 hours of ingestion. So often we don't see our patients early enough. There are very few antidotes, and even these are limited by availability. I've listed some of the common ones here, but there seems to be this knee-jerk reaction to give antidotes. But in fact, patients have to earn their antidote. And a lot of it comes back to whether or not they've taken a toxic dose and whether or not they have any indication of systemic toxicity. There are elimination techniques for specific toxins. For example, urine alkalinization for salicylate toxicities. You give IV Sodabic to increase the pH, the blood pH, and then this alkalinizes the urine. Something like multiple dose activated charcoal is quite useful for substances which undergo enterohepatic circulation, and the charcoal actually acts more like a dialysis mechanism rather than actually binding what's in the stomach. And then we know that hemodialysis is excellent for those toxins which are dialyzable. So whenever you're dealing with a poisoning, there's always a number of resources that are available to you. Cindy's already mentioned the Poisons Information Helpline, which can give you immediate advice. And you can also tell your patients that they are welcome to call us directly. Common poisonings are covered in the pediatric standard treatment guidelines, and we contributed to the content, so it's up to date and really got the latest information. But Afritox Poisons Information Database is the flagship product we want to highlight today. It's developed by the staff at the Red Cross Poison Center and has over 40,000 products on it, including pharmaceuticals and household substances and all the environmental toxins and chemicals. And it's available free of charge to all government hospitals. And I'm going to show you its functionality using real cases that we've encountered. Many of the pharmaceutical products that are on Afritox, we've shared the treatment protocols with EM Guidance. And so you might find our protocols there if you have the app on your phone. So Cindy and I are going to take you now through some common causes of poisoning and highlight just a few key concepts. So as shown earlier, medications are the #1 toxin involved in poisoning in children. And we know that paracetamol poisoning is common and there's an effective antidote. But decisions on when to use N-acetylcysteine might be tricky. So I'm going to run you through a case now and also use Afritox to show you, to highlight those protocols. Hopefully you can see me there. All fine?
Yes, we can.
Okay, so an 18-month-old child, 11 kilograms, drank 70 mils of the green paracetamol syrup that we all know is dispensed by the clinic. In Afritox, you type in paracetamol in the search function and you press enter. And what should happen as it comes up is that you'll see there's this huge list of names of substances which contain the name paracetamol. I can either go directly to paracetamol, but in this case, I know that it was the Bars paracetamol syrup that this child ingested. So I click on that and it takes me to this paracetamol group. All right. Then under generic composition, if I didn't know the name, I would have been able to see what kind of formulations there are for syrups and tablets and all sorts of things. But because I know what the product is, I go and I see that Balme's pediatric syrup has 24 milligrams per ml of paracetamol. So this child took 24 times 70 mils divided by 11 kilograms. And so when we go to toxicology, we can see here, and it's always a bit complicated for paracetamol, but we can see here that for an adult or a child, the oral toxic dose is 200 milligrams per kilogram or 10 grams. This child took 153 milligrams per kilogram, so she has not taken a toxic dose, and there's nothing more that needs to be done. And this means they don't need to be admitted, they don't need a paracetamol level, and they can go home. And you just need to take the opportunity to assess the home circumstances and counsel the parent on home safety. Let's go back again. So now this child took Panado, 10 tablets. Now we all know Panado, and I'm going to put it in here, up at the top. Enter. And you'll see that Panado comes actually up with a lot of options. So when someone says to you they took Panado, you need to take the time to actually ask them which Panado it was. We go in here to the basic Panado, and we see that under specific composition for Panado, which is a brand name, is that either it's 500 milligram per capsule or per tablet. So if the child took 10 of these, it's 5 grams, which equates to 455 milligrams per kilogram. So like I said to you, 200 milligrams per kilogram is the toxic dose. So now we know that we need to go to the treatment for this patient for paracetamol poisoning. And it really can guide you on how to give supportive care, the timing of taking levels, and how, most importantly, how to treat the patient and interpret the nomogram. And I'll show you here that we scroll all the way down. We tell you different scenarios, different N-acetylcysteine. And if we come to the end of our thing here under information, there's the nomogram. We can click on that, and hopefully you can see that now my paracetamol nomogram has come up. So that's where it's meant to be quite useful, and you can plot the levels that you might take. So this case clearly demonstrates the use of the toxic dose principle in triaging patients and the array of information that's available on AfriTox. But all paracetamol ingestions are not the same. And so I'm going to tell you about another child who's a 2-year-old who's been febrile for a few days, and the parents have visited multiple pharmacies, and each one has provided a different antipyretic and analgesic syrup, and the parent has been using this as instructed. And after 5 days, the child develops severe abdominal pain and becomes confused. And inevitably, this child's been at the GP before and then arrives at you as the pediatrician. All right. So when we take a good history, we find that the child's being given all these syrups that are used. We go and we look again and we see what it is, and we can see that, okay, they took Ponstan. That luckily contains mefenamic acid, so that's not a problem. But then they've taken pain block syrup. So we type in pain block, and here's the pediatric syrup. And we go and we can see that this is a mixture with multiple ingredients, and it contains alcohol and paracetamol. So that's the one product they've been using. And if we go back again and we see that also they've been taking still pain, all right, we add that in. And when we get to still pain syrup, which is what they've been given, it's also another mixture, and we can see that it contains codeine, promethazine, paracetamol, and we call some minor constituents. So this case then illustrates that it really is repeated supratherapeutic ingestion, and we need to calculate all the paracetamol values together to know how much this child might have taken and then treat accordingly. So you'll see here that in the toxicology of paracetamol, it shows us a whole lot of cumulative doses and when to initiate treatment. It also shows us how AfriTox ranks mixtures in order of relative toxicity, according to the ingredients there. And if we go back to our initial 11 kilogram, 18-month-old child who ingests 30 mils of still pain syrup, it will be a toxic dose here for codeine. When we note at that, we can open it up. It'll be a toxic dose for promethazine, and the treatment protocols we can click to there, but it's actually not a toxic dose for paracetamol. Paracetamol poisoning also occurs, and I want to show it to you here. We're seeing it more and more as an iatrogenic overdose with the use of pafalgan. And so patients are given too much in the hospital context. And we have here that you can give an IV toxic dose of 60 milligrams per kilogram. We don't use the nomogram for these children, and often they need to be given NAC empirically if they've been given more than a toxic dose. And the last thing I want to show you on Afritox whilst I can is the dosing for N-acetylcysteine, which you can go down here and note that now we no longer give the 3-bag regimen, but actually it's a 2-bag 20-hour regimen. And the first 200 milligrams per kilogram is given over 4 hours, and then the second 100 milligrams per kilogram over the next 16 hours. And this has actually been shown to have less errors in both prescribing and dispensing. It's less time consuming for very busy nursing staff. And importantly, also patients actually have fewer anaphylactoid reactions. So now let me just stop sharing Afritox, and I just want to get back to the our talk, share that again and moving on. Okay, so household products are the second most common cause of poisoning in children. And unfortunately, paraffin is still so common in low and middle income countries. And it's often decanted into empty water bottles or juice bottles, and of course looks just like water. Even a small stip can do harm and cause a chemical pneumonitis. So oxygen and supportive care are what is required. And it's a little interest area of mine, and antibiotics really should not be given routinely, but only for children who develop a secondary infection on top of their pneumonitis. There were some child-resistant caps that were distributed by the petroleum industry, but I'm not quite sure how available these really are today. Jay's fluid is often a regular culprit of childhood ingestions, and this contains a number of phenols that can cause corrosive injury. And we know that batteries can also cause injury in a few ways. So there may be a foreign body that cause obstruction and pressure necrosis, but they also cause an electrical injury, which leads to quite severe corrosive damage, and they must be removed if they do not pass through the GIT spontaneously. But all these products can be found on Afritox with all their relevant formulations. And Cindy is going to continue now with some pesticide poisonings.
Thanks, Kate. So let's look at pesticides, the third most common cause of poisoning in children. And as I mentioned earlier, these have been shown in many studies to cause more severe poisoning compared to other toxins, with patients requiring ICU admission and longer hospital stays. And this top table on the slide shows data from Red Cross Children's Hospital between 2003 and 2017. And it illustrates this clearly, showing the high numbers of sickest children characterized by a poison severity score, or PSS, of 3, which is severe poisoning, or 4, which is death. And you can see that those children poisoned by pesticides account for the highest numbers. And in fact, during this period, half of the poisoning deaths, 8 out of the 16, were due to pesticides, and mostly these were organophosphates. Now, the bottom table shows more recent Red Cross Children's Hospital data, and it compares illness severity by the type of pesticide. And one can clearly see, as Kate has mentioned, the difference between exposures to anticoagulant rodenticides, such as Ratex, which occur very commonly and seldom cause harm, compared to the poisoning severity of the cholinergic poisonings. And these will be due to organophosphates primarily. Now, as cholinergic poisoning is both very common and often severe, we thought it worth highlighting some key management issues. So cholinergic poisoning can result either from branded products containing organophosphates or carbamates, or from products sold in the informal sector as rodenticides, the black granule that I'm sure we're all quite familiar with, known by a number of names, such as haloperidol, which is a Sesotho word literally translated meaning you will never see the sunset. Now, this is often added to food, which is put out for rodents, And this is commonly how children are poisoned. They find the food that has been mixed with the rodenticide. Now, over the past few years, some of these black granule samples have been tested and shown to contain organophosphates, such as turbophos, or carbamates, such as aldicarb. Now, in a moderate cholinergic poisoning, a child may present with an altered level of consciousness, vomiting, diarrhea, secretions with a wet chest, pinpoint pupils, and muscle fasciculations, a kind of a full house. But we need to also be aware of amitraz and poisoning due to this pesticide, which is commonly found in cattle dips and also dog dips. And it can sometimes be confused with organophosphate poisoning in that patients present fairly similarly with an altered level of consciousness, bradycardia, respiratory depression, and pinpoint pupils. But the differentiating factor is a total lack of secretions in amitraz poisoning. Unless, of course, with the depressed level of consciousness, the child has vomited and aspirated, and that can make this differentiation quite tricky. But it is important for us to try and differentiate the two, as unlike for organophosphate poisoning, there is no antidote for amitraz, and atropine should not be used. Now, in a severe poisoning, when intubation is required, please remember that neither succinylmethonium nor mivacurium should be used, as both are in fact metabolized by plasma cholinesterases. And so in the presence of organophosphate poisoning, their metabolism is reduced, and this can result in prolonged paralysis post-intubation. And then lastly, a comment about atropine. So organophosphate poisoning is a condition where an antidote is essential, and in this case, it's both cheap and effective. And some randomized controlled trials have shown that morbidity and mortality are significantly reduced when atropine is bolused rapidly and incrementally, with double dosing every 5 minutes until the patient is atropinized. Now, atropinization is characterized by the drying of secretions. We do not need the pupils to normalize in size, as they tend to resolve much more slowly. And once atropinized, the patient should continue to get atropine as an infusion for at least 24 hours, titrated carefully according to the patient's response. But not all severe pesticide poisonings are due to organophosphates, and the following case will illustrate this. So this was a family living in a local township. They'd recently had a new baby. And on a Sunday earlier in this past year, almost the entire family presented to the local district hospital emergency department with gastro-like symptoms: diarrhea, vomiting, abdominal pain. The patients who presented were a 4-week-old baby, her mother and her 2 siblings, aged 7 and 12, and a 16-year-old cousin. And on admission, all were generally stable, and management for their gastro was initiated. However, and rather surprisingly, the neonate began to deteriorate after a few hours and developed significant pulmonary edema requiring ventilation for oxygenation, as well as severe cardiogenic shock requiring massive doses of adrenaline. And the baby's troponin levels were also noted to be very high. And unexpectedly and tragically, she never became stable enough for transfer and died at the district hospital on maximum ventilator settings and doses of inotropes. The rest of the family remained relatively well, although all of them had a very significant, if transient, leukopenia, as you can see in this slide. The white cell count was 1.19. Now, with a mass presentation like this, a toxin was on the differential diagnosis list. And on further questioning, it was learned that due to the concern for bringing this newborn baby into a house which had quite a significant rat infestation, the father had obtained some rat pills and placed them in every room of the house on the Saturday night. The product was identified as quickphos, aluminium phosphide, an extremely toxic pesticide reserved only for registered pest control agents. On contact with moisture, even the moisture in the air, aluminium phosphide releases phosphine gas, a potent toxin, causing mitochondrial failure and, in severe cases like this baby, resulting in cardiac decompensation with refractory shock, as well as pulmonary edema, renal and hepatic failure. And our Eastern Cape colleagues with us today may know this as tank pills. Now, it was a huge tragedy, as you can imagine, and surely it should not happen again. It should be prevented. Now, fortunately, the treating pediatrician notified this case, as she was aware that pesticide poisoning is a notifiable medical condition. And the NICD are currently the responsible body for collecting and collating data from NMCs, notifiable medical conditions. And notification can be done using a paper form, or preferably much more quickly and easily by using this app, which can be downloaded free of charge from the app stores on your phone. And the URL is there on the slide. So once the notification was received by environmental health, the allocated environmental health practitioner, or EHP, did a thorough investigation, which involved a number of visits to this family and persistent attempts to identify the source of the quickphos, and the actual container is pictured here. It was traced to a hardware store in a small town in the area, who sold the product to the father without following the required regulatory requirements. In other words, only to be sold to a registered pest control agent. Now, more work needs to be done in this area, but as a result of this case, the issue's been highlighted and flagged again, and retailers advised that they will be held responsible for unauthorized sales. And really, from a public health perspective and advocating for children in particular, I'm sure we would all like it if the regulations around highly hazardous pesticides were better implemented. And in fact, it would be even better if many of these highly toxic substances were restricted or banned altogether. But as I've learned, for government to do this, they need data. And the best sort of data is us notifying these cases. So a reminder and a plea. Symptomatic pesticide poisoning by any pesticide under any circumstance should be notified. The case definitions are available on the NICD website, and simply interpreted, one doesn't need to know the active ingredient or even the exact name of a pesticide, but if there's a history of pesticide exposure, plus the presence of characteristic symptoms or signs, and the time frame from exposure to illness is reasonable, please notify the case. So let's move on to one final case from me. We're moving away from pesticides now to a much less common but equally devastating poisoning. So this little boy presented at 2 years, 8 months of age. His presentation was a gradual one. His mother described her previously happy and energetic little boy who had, over the previous 3 months, stopped playing. He lost weight, he became very lethargic. He was also constipated and had episodes of fever. And it was noted he had a rash between his toes and on his hands, as you can see here. And these pictures are used with permission. At presentation, he was drooling and weak. He just wanted to lie down. Now, on examination, he was well grown for his age, but he had global hypotonia, power of 4/5 throughout, with pronounced head lag, bulbar dysfunction, and an unsafe swallow. He was also constipated. He'd had resulting rectal prolapse and treatment from the surgeons. And he also had this rash on his hands and feet. So he was admitted for a broad workup, MRI, feeding assistance due to his impaired gag reflex. He was seen by neurology and dermatology, and it was the dermatologists who asked us as the Poison Center for an opinion. And what immediately came to our tox-wired minds was Pink's disease, or infantile acrodynia, which was prevalent in the first half of the 20th century following the use of mercury-containing teething powders. Presentation typically included symptoms of irritability, pink discoloration of the hands and feet, hence Pink's disease, and with this desquamating rash and polyneuritis. And all of it was attributable to chronic mercury exposure. So we suggested a mercury concentration be sent on this little boy, and the results came back hugely raised. His corrected urine concentration was 512 micrograms per gram of creatinine, and his blood concentration was 41 micrograms per liter. How could this possibly have happened? How could a small child like this be so exposed to mercury? Now, fortunately, the clinicians in this case also remembered that mercury poisoning was notifiable, and so this was done. And 2 home visits were made by the EHPs to the family of this child to investigate possible sources of mercury. And although they were unsuccessful at finding the source on the first visit, they did nevertheless provide heavy metal poisoning awareness education. But a second visit was required, and this shed more light when the child's mother described using elemental mercury quicksilver, as you can see on the slide, to clean her jewelry, which she did by boiling on a little stovetop in their very small and poorly ventilated bedroom where they all lived. Further, the mother's partner was involved in repairing electronic goods using lead solder, which you can see here, and again, in their bedroom. So solder is not a source of mercury, but it may indeed be a source of lead. And so it was suggested that the child had a blood lead concentration checked as well. And it also came back elevated, not so much, but it's 6.72 micrograms per deciliter. But it is a concentration at which lead poisoning should be notified. But it was the maternal grandmother who finally let slip that the other cottage industry the mum was involved in was the manufacturing of tick dollies or pipes used for smoking tick, using fluorescent mercury-containing tubes. So there were multiple sources of mercury exposure for this child. And in fact, simply removing him from the environment during his stay in hospital resulted in a marked decrease in his mercury concentrations. Now, I won't go specifically into the toxicity of mercury itself, but I did want to highlight some key issues around heavy metals, and particularly lead and mercury, as they have similar effects. So the heavy metals are found in a variety of chemical forms, elemental, organic, inorganic, and their toxicity depends on their form, and as Kate mentioned earlier, their route of exposure. For example, inhalation of mercury fumes is very harmful, as in this case, whereas it's the ingestion of lead-contaminated dust particles, which is the most common source of lead poisoning in children. Heavy metals are essentially cellular toxins, particularly affecting the nervous system and causing a wide variety of neurological effects, such as behavioral disorders, tremors, memory loss, insomnia, headaches, cognitive motor dysfunction, and developmental delay. And children and pregnant women are most vulnerable due to the sensitivity of the developing brain in children and through transplacental exposure of the sensitive fetal brain. So please remember the heavy metals when you're faced with children presenting with kind of chronic non-specific symptoms, GIT discomfort, constipation, fatigue, behavior problems, as these can all be part of chronic heavy metal exposure. And diagnosis is simple. It just requires a single blood or urine sample. Now, the key to treatment is preventing ongoing exposure, and so identifying a source and either cleaning the environment or removing the child from the environment are critical. Supportive care is also obviously very important in longer-term management. And in a severe poisoning, chelation therapy may be required to enhance elimination. And if you look at the table here on the slide, you can see that in this case, the little boy's urine mercury concentrations showed very impressive increases, the blue columns, once he was on chelation therapy. And in fact, you can see even being in hospital out of his mercury-laden environment resulted in clinical improvement and his mercury concentrations dropping even before chelation was started. And happily, we can say that within a few months, he was almost back to his normal self, running around and playing, no more drooling, although he did still have some residual global hypotonia. And so, as we have seen, metal poisoning has serious and long-lasting consequences. And as this kind of poisoning is invariably due to environmental contamination, identification of the source and risk reduction are really important public health issues. And that's why both mercury and lead poisoning are notifiable. And unlike for pesticide poisoning, and please note it's listed under the NMC apps as agricultural or stock remedy poisoning, but unlike for pesticides, the case definitions for lead and mercury are very straightforward, as shown here. Mercury poisoning requires a urine or a blood concentration of greater than 10 micrograms per liter, and for lead to be notified, there simply needs to be a blood level greater than or equal to 5 micrograms per deciliter. So that comes to the end of my case presentation. I'd like to hand back to Kate now to close our session and take us through some of the summer poisonings that are keeping us very busy at the moment.
So we are on the way towards wrapping up. This is our busy snake bite season and also scorpion sting season. So we thought we couldn't leave without giving you some information in this space. So the child on the left is a 22-month-old boy who was bitten on the foot by a snake in Butterworth. The parents tied a tourniquet around the thigh and took him off to hospital. And the leg was swollen up to the thigh, and there was bruising and a faint pedal pulse. Luckily, the snake was taken with the child, and identification revealed it to be a rhombic night adder, which is on the bottom left. But for the rhombic night adder, it causes cytotoxic envenomation, but polyvalent antivenom is not indicated, and this child did well with just rest and elevation. The child on the right, with a very similar type of picture, is a 3-year-old who was bitten by a snake in the northwest, and she was taken to the private hospital and given the usual cocktail of Solicortiv, Rocephin, Voltaren, and Impiped, all of which were completely incorrect, except for the Impiped. The lower limb was tense and swollen and bruised, and the pedal pulse was present. The child was then referred to the government hospital, where thankfully the doctor contacted the Poisons Information Helpline, and Cindy happened to be on call, and she was able to identify the snake as a puff adder, which is the picture in the middle, and she recommended the correct treatment of polyvalent antivenom. And there was a little complication in this child because the hospital didn't have enough vials of antivenom that were required for this patient. And so a decision had to be made as to whether or not to transport the patient to another hospital, or whether or not the hospital must procure other vials of antivenom from the surrounding area. But the child did well. So these cases illustrate cytotoxic snake bites, which are by far the most common in South Africa. Cytotoxic ones are usually due to puff adders, as we've shown you, the Mozambique spitting cobra, night adders, and stiletto snakes. As in these cases, snake identification can guide treatment and the correct use of antivenom. But often, and in most cases, the snake really is not identified. And we manage patients according to the syndromes of cyto, neuro, and hemotoxicity. For cytotoxic bites, just a few things to highlight is that compartment syndrome is rare, as snake venom is actually injected into the subcutaneous fascia and not the deeper compartments. And this can be visualized on simple ultrasound. So the take-home message is please don't do fasciotomies, and don't only advise your surgical colleagues when the child requires debridement of the necrotic tissue. Steroids and antihistamines are all too routinely given, but they shouldn't be used, as a snake bite causes envenomation and not an allergic reaction. The only allergic reaction is to the treating staff, who panic when the live snake is brought into the emergency department. Adrenaline is given before the administration of antivenom to reduce the incidence of reactions, and if a reaction occurs, it can also be used again. Neurotoxic snake bites are far less frequent. In South Africa, we worry about the Cape cobra and some mambas and the snouted cobra. But the really important management principle here is that patients become paralyzed and lose their ability to breathe. And so this is where respiratory support really does save lives. If you have a patient like this that arrives in your casualty with sudden onset paralysis, please do not give up. All they need is respiratory support, which can be easily given via ventilation, and then one can provide access to the relevant antivenom if required. There's also a lot of talk in the press about polyvalent antivenom at the moment, and that it's out of stock. The locally produced SAVP product was in short supply when we had severe load shedding earlier this year. But they have told us that they've caught up production and distribution for this busy summer season that we seem to have every year. And all you need to know about snakebite is very beautifully covered in the recently published snakebite guidelines in the SAMJ this year. So that really brings us to our take-home messages for today. Firstly, please take a good history to determine a toxic dose, as this is key to making decisions whether or not to treat a patient. Effective emergency treatment and supportive care are really the mainstay of management and likely to ensure a successful outcome. When we're looking at resources, Afritox, as we've shown you, hopefully, and just a small amount that we've shown you, contains a variety of local information on toxic doses and treatment protocols. And it really is easier to use than the telephone service for our complex patients. But the Poisons Information Helpline is still available 24/7 for now, and not only to medical personnel, but also to members of the public. Remember that pesticide poisonings may result in severe morbidity, and they must be notified so that we can have an impact on the public health side of their poisoning. And if you're interested or seeing snake bites in your emergency departments, or as pediatricians expected to manage them, then please take a look at the excellent new guidelines that were in the May, June, and July SAMJ CME editions. If you'd like to learn more about Afritox, then please visit the website and send us inquiries. We really would like to hear from you. So thank you very much.